Thank you, respected chairperson. At the outset, I must like to thank Amitabh sir, Shomik sir, and Shunetra for having me here. The first thing is that this session was originally due to taken by Dr. Lakshmi Nagendra ma'am. So she couldn't come. So ma'am has given me the responsibility to talk. So important thing, we'll talk about optimizing bone health and diabetes. So I'll try whoever present here in the conference to understand what are the bone diseases which can happen in diabetes and how we can manage it. So the bone mineral density alterations or poor bone quality of in diabetes was actually way back reported in 1948, then in 1981, and then in 1991. So the concept of low bone mineral mass in diabetes was there for last 60 to 70 years. And diabetes mellitus increases the risk of fracture. If both type 1 diabetes as well as type 2 diabetes, the relative risk of around 1.23 in type 2 diabetes or around 3.3 in type 1 diabetes. So look at one of a representative case in our institute. So a patient with a poorly controlled type 2 diabetes with a long-term history of back pain and a postmenopausal status for 10 years, and she has sustained a Colles fractures 5 years back. And she undergone a bone mineral density testing in DEXA. I think DEXA was dealt yesterday by Shomik sir. So mostly we know the basics of the DEXA. So this is a lumbar spine DEXA, and having a T-score of minus 3.8. She's a postmenopausal, so we'll see the T-score. So it's a severe osteoporosis which we can see. Now the question is, what are the contributing factors? We know she is a postmenopausal, long-term diabetes history, and having a previous history of fragility fracture. So both of them, this postmenopausal status as well as poorly controlled diabetes, are actually important for this fragility fracture and low bone mineral density. So after a fragility fracture, the risk of another fracture is around 2 times more, and that is usually in the first 6 months, but only 20% receive treatment for the secondary fracture prevention. So this is a very interesting data in Japanese Ministry of Health and Welfare and Labor, that where they put the importance of fractures in osteoporosis. So we can see that is as well as important as more than important than the heart disease or in the stroke or high blood pressure disease. So important is that the diabetes, we need to know it's a chronic disease with substantial comorbidities, and among the comorbidities, low bone mineral density or osteoporosis is important, but unfortunately takes a backseat. And we have a void of understanding how this metabolic syndrome, obesity and diabetes affect the skeleton. So just initially look at Indian data, ICMR India study from Dr. V. Mohan's team. So it having a total subjects of around 54,000, and they had seen that diabetes was associated with significant high number of fractures compared to pre-diabetes and without diabetes. And if we see in the multivariate logistic regression analysis, the risk factor for fractures, diabetes, the odds ratio was 1.3. And interestingly, in this study, what we got there, that the awareness among the type 2 diabetes, that was around 56.2%, were aware of the risk of fractures. But however, almost 3/4 of the patients had a misconception that osteoporosis first presents with bone pain and then patient goes into fractures. So now look at to the diabetes related risk factors which can lead to fragility fractures or low bone mineral density. The general risk factors is obviously prior osteoporotic fractures, more than 65 years of age, low BMI, female sex, malabsorption, glucocorticoid use, rheumatoid arthritis. These are the usual factors we come across any osteoporosis evaluation. But some diabetes specific risk factors are there. They are not very consistent, but various studies have shown. So typically lumbar spine or hip T-score, if it is minor less than 2, or frequent hypoglycemic episodes, or diabetes duration of more than 10 years, or diabetes medications, specifically insulin, thiazolidinones or sulfonylurea, poorly controlled diabetes, so HbA1c of more than 8%, and obviously microvascular complications. Now, what are the various pathogenesis of this diabetes bone disease? I'm not going into very much detail, but just will touch upon briefly. So one of my paper published, a chapter will be upcoming published in RSSDI handbook. So the abnormal bone phenotype in diabetes can be divided into 4 gross types. So there can be alteration in the bone mineral density, what we have currently consistent data that type 1 diabetes generally have a lower bone mineral density. Type 2 diabetes can have lower, can have normal, can have higher as well. But most important, there is a disruption of the bone microarchitecture. So not only bone mineral density affects the fracture, it's also the bone microarchitecture that is also affected in diabetes, and that is there in both type 1 and type 2. The diabetes is typically associated with low bone turnover stage, and last point is most important. Even with the normal BMD, they are having increased risk of fracture that is typically seen in type 2 diabetes. Now about the pathogenic mechanisms, there are some common between type 1 and type 2, and there are some specific for one of the disease. So type 1 diabetes with an insulin in deficiency, they are having a low IGF-1 and GH resistance at the site of liver. So that is a very important mechanism for poor bone mineral density. Advanced glycation end products and reactive oxygen species are there in the both type 1 and type 2. Increased Rankel activity leading to osteoclastic activation in type 1. Decreased osteoprotein activity leading to poor osteoblast generations in type 2 diabetes. Diabetic kidney disease, especially in type 1 diabetes, leads to secondary hyperparathyroidism. In type 2 diabetes, another very important mechanism is adynamic bone disease. And talking about complications, the microvascular complications, so in diabetic retinopathy, there is high VEGF and abnormal bone morphogenetic proteins that causes also poor bone mass, as well as the diabetic neuropathy, which affects alpha and beta adrenergic receptors, which are heavily expressed in osteoblast. Now, for a diabetes patients come to our clinic, our OPDs, how to evaluate for bone health, which is unfortunately less seen, or rather less considered. So very important two things we need to know: how to predict the fracture risk and how to treat that. So how to predict the fracture risk? We need to do the bone mineral density by DEXA. So what are the indications of DEXA in our Indian guidelines, ISBMR? So obviously women more than 60, men more than 65 we need to do. But postmenopausal women less than 60 and men having age of 50 to 64, if there is a concerns of osteoporosis based on the clinical risk factor profile. So clinical risk factor includes diabetes, we need to remember. And even women in the menopausal transition, not in the postmenopausal phase, if they have a specific risk factor with increased fracture risk, again, diabetes is such kind of that. Patients having fragility factor before 50 years, we should do. And last but not the least, diabetes is a specific condition also have been mentioned, where we need to have an individual having a condition of diabetes, we need to assess for the osteoporosis. So among these 5 indications of osteoporosis, 3 indications actually include the indications of diabetes. So actually, if it's all these indications is there and the patient is diabetic, we need to go for a DEXA assessment.